Good morning, good afternoon, whenever you're watching this. My name is Donna Fick, and I am a professor at Penn State. I'm also a nurse scientist, and I'm also a nurse that's board certified and trained in the care of older adults or geriatrics. And hopefully, if you're watching this today, you are a resident or older adult living in a nursing home, or a family member or friend, someone that helps care for or cares about someone living in a nursing home. And so I'm going to talk with you for about 25 minutes today about medication use in older adults, thinking about what residents and care partners and families can do as they think about medication use in older adults. I do want to acknowledge that this is part of a project called What Matters Most, and you'll hear more about that in a couple of minutes. And this project is funded by the Health Resources and Service Administration. And there are three of us, three universities actually working together: Penn State, Johns Hopkins, and the Virginia Geriatric Education Center. So thank you to our collaborators and also to our nursing homes that have been partners in this endeavor. So I have a couple of objectives today. We will talk about whether residents are receiving two medications, whether or not they might be receiving potentially harmful medications, and how we can think about that or address that. And most importantly, how to provide medications safely and effectively within something we call the 4Ms framework, and how different roles, including the role of the resident themselves and the family and care partners, can accomplish these things. And then I want to make three more points about content. And that is that medications are important. And so even though you'll hear me say a lot today about medications to avoid, or how we might discontinue medications, medications are important. They save lives. They can help with symptom and pain relief. But the issue here is that persons living in a nursing home, and I know that's not all older adults, but persons living in a nursing home and older adults tend to be much more vulnerable to some of the problems that we can run into with too many medications due to changes in aging and disease and condition. And we don't have time for all that today, but I'll give you a couple of examples. For instance, as we get older, and this is happening to me now as I am lucky enough to age, we have decreased lean body mass and an increase in subcutaneous fat. And so drugs, many of which are what we call lipophilic or fat loving, tend to build up over time and to become more toxic. We also have less total body water as we age. We also have changes in how drugs are distributed throughout the body related to some of these things. And the overall thing that happens usually is that they increase in toxicity and lead to problems. The second point, which I'll make over the next couple of minutes, is that medications should and must be reviewed at regular intervals. This is usually at least monthly in a nursing home, and most importantly, anytime there's a change, such as an illness, a hospitalization, an ER visit. And during these reviews, we should have open discussion and communication with you, the family member, and the resident at a nursing care plan meeting, or any time that you have concerns when you're visiting about what the medications are for. And we should be talking back and forth with the resident about how they are doing when they take the medications, how they feel, how it feels. Perhaps they're on too many medications, perhaps they're on 9 or 10, and it interferes with their ability to eat or to enjoy food. And then lastly, every time that medications are reviewed, we should look at it as an opportunity to say, do we still need this medication? Is it helping or is it harming? Should they be continued or should they be discontinued or tapered? And we often refer to this discontinuation as deprescribed. So that might be a new word for you, deprescribed. So we'll talk about a real person that we did make up the name, Polly Farmer C. She's 78 years old, and she came to the nursing home about 3 weeks ago, and she's new to the nursing home. Polly has diabetes, arthritis, high blood pressure, memory loss, hearing loss, by the way, which is very common. It's in the top 3 chronic conditions as we age. And she has renal or kidney disease. She is on 11 medications, not including what are called PRN or as needed medications. And she is on 5 Beers criteria medications to avoid. And we're going to talk more about this. I'll tell you what those are, including muscle relaxants for back pain and lorazepam that was prescribed years ago for work-related stress, and then 2 medications for sleep. She has not been sleeping well since she moved to the nursing home. She does not come to the group dining area often, and staff report that she seems a little restless and is repeating herself a lot. We know that she likes to garden. She enjoys country music. She is retired from managing a retail store and has 2 children and a grandchild. Also, she had some losses. She recently gave up her driver's license and it's been difficult for her granddaughter to visit, so she misses her. And when I talk about medication use, I'm going to tell her, hopefully this isn't the first time you've heard this, but if it is, that's okay. I'm going to talk about it in the context of something called the 4 M's framework. These are things that we have strong evidence or science behind, and we know if we try to do these 4 things or focus on these 4 things as a framework with every older adult, that they actually get better care, that the quality of their care improves. And these are what matters, which we'll talk more about, but it's asking the older adult what's important to them. Medication, which we're going to talk about today, and that's avoiding medications that are problematic or high risk, and making sure that medications are lined up with what matters to the older adult. Mentation or mind, that's things like memory impairment or feeling depressed or acute confusion that can be caused by medication sometimes. And then mobility, so making sure that the older adult is able to move through the nursing home or around their room to do the things that are important to them. I do want to give you a little background. This is a report. Anybody wants this report, you can access it actually online, or I can send it to you. And it's by the Lown Institute, and it's called Medication Overload, America's Other Drug Problem, How the Drive to Prescribe Too Many Medications is Harming Older Adults. And a couple of things that they talk about in this report is that 5 million older adults sought medical attention for adverse drug events in 2018. So 5 million older adults had drug-related problems. 42% of older adults take 5 or more prescription medications. And when we talk about polypharmacy or too many medications, the sort of accepted number in the literature is 5 or more. So keep that in mind. We know that there was a 200% increase in polypharmacy or too many medications over 20 years, that it resulted in hospitalizations, preventable hospitalizations, and 150,000 premature deaths over the last 10 years. So again, I start out by saying, remember, there are some good medications. I want to say that again. So you see here on the left is this sort of indicated good polypharmacy where people need these medications. But then there's this medication overload, which is things that might seem like they're indicated, but they're really not benefiting. And no one's stopping to say, is this still helping them? That also could fall into the no longer necessary. So sometimes we're put on something for a short-term problem or at a younger age and then never taken off of them. The other one, which I don't think we see as much in a nursing home, is unnecessary over-the-counter. What we do see a lot of are unnecessary vitamins and supplements. Most individuals, if they're eating properly and doing other things, don't need all these supplements. And then there's the never necessary, and that's the list we call the high-risk list, or the Beers criteria that I referred to. And the other thing I want to say is, I'm not just going to say, boy, this is a problem. What do we do about it? We actually have tools and lists that are backed up by science on medications to avoid in older persons and in persons who are vulnerable for other things besides age. You can click on this link or you can Google it, but there's something called the Health and Aging Foundation, and they have a list of about 10, so it's a shorter list. You can go to the AGS, which stands for American Geriatric Society Beers criteria, and they have a longer list. You can also reach out to me to get that list. And then just in general, I'll say that there are types of medications that we know are higher risk in older adults. Those that impact the brain and central nervous system or cause dizziness or falls. Examples are opioids, sedative hypnotics for sleep, anti-anxiety and antipsychotic drugs. And then lastly, I'll say on this slide is that just because a drug is on a list, we should never stop it suddenly without, again, making sure it aligns with what matters to the older adult and talking with your provider. Because many of these medications, you'll have problems if you stop them quickly, and so they have to be tapered. And the other thing is that medications, thinking about discontinuing medications is an area where we can make a big impact on the quality of care. Again, we have these evidence-based lists that I showed you. I want to point out this one study because it's pretty striking, and there are a couple others that have also found similar results. This was a study in 2019 of almost 60,000 older adults. And these older adults were age 55 and older, so they weren't even that old. They weren't 85 or 75. And those that were taking a class of medications called anticholinergic, which is where a lot of those medications I talked about, like sleep medications, anti-anxiety medications, those are all in this class called anticholinergic. They were 49% more likely to develop dementia. Again, this is association, it's not causation, but we have some evidence that these drugs may not be good for you. That's just one example. Now I want to switch a little bit to how we can help people like Polly and how we can think about communicating and how families can help think about communicating with other staff members, with the physician, the nurse practitioner, the CNA, the therapist, and how we can communicate together. Again, I'm a science person, so I like to think about the evidence. I'm also a story person. And I want to show you this. So this was a study that they did with over 800 older adults in residence. And they said, what kind of things are most important to you when you thought about coming off of a medication that might be harmful? And the number one thing that was effective was this issue of an increased risk of side effects or adverse effects. The other one was thinking that they might be on an overall harmful number of medicines. The other thing that people were more willing to do was to work together to reduce a dosage of a medication. So sometimes you might say, I'm not really ready to stop it right now, but let's begin to go down on the dose. And you can see the ones they didn't feel were helpful is they didn't like it when someone said, no, look, this won't help you anymore, or we're going to deprescribe this because you can become dependent, or it's not going to help you. People that didn't resonate with them. And as a matter of fact, sometimes when we use that kind of communication, they felt like you were giving up on them. And so again, the top ones that were more effective in communicating were things like increased risk of adverse effects or a harmful number of medications. Again, some of the points that resonated with both older adults and their caregivers were this balance of benefits and harm, function and quality of life were important. The other thing is that medications often can cause new problems. So the clinician saying, look, there's no easy answer. I know you feel this medicine helps you sleep, but actually medications for sleep only work short time, and we don't want to do harm to you. I said this earlier, but even as we grow older, even a medication that we might have been taking a long time, so we say, hey, we've been taking this forever, we've never had a problem. But as our body ages and it's no longer 55 and it's now 75, we can and we do have problems. The other thing I wanted to show you is some what we call like things that get in the way of deprescribing. Again, and these are things we have to communicate with, is that sometimes, so on the right, or sorry, the left, is patients and caregivers. So sometimes we have to recognize that and I'm sorry to use that word patient, should be resident, is that if we try to take away a medication, or if we try to talk with them about it, we might feel like we're giving up on you, when that's not really the case. It's because we're worried about the side effects. They're afraid, understandably, that the disease might get worse. They are fearful that the symptoms will disappear. And sometimes, even when it's not helping them, they might believe it's necessary. Some of the things that might get in the way on the staff side are that they're not always trained in how to deprescribe or talk about deprescribing. They are worried about how the older adult or the family will react to this. Sometimes some of the policies in nursing homes don't always allow us to have this open conversation. It has also been found that those who live in more rural nursing homes have a harder time dealing with some of this. And then lastly, sometimes we don't want to upset the other specialist. So maybe this was, I'm making this up, but like a heart specialist or a neurology specialist that prescribed this drug. And we're grateful for their care and we're afraid to upset them. So what can we do about this? Well, the biggest thing is to realize that this is a process. It takes time. And so if someone's on 10 medications or 15, you're not going to get rid of all those in one day. And maybe most of them you need them. And so it really is about establishing a partnership. Thinking about this as something, remember I said, think about this as an opportunity. Think about this as a long-term goal, and have mutual listening skills and relationship and form a good relationship. Some questions that can help us form a relationship, remember, and this comes back to the 4 M's, is saying things to your loved one, if this is a family watching this, is that I want to understand what is most important to you in our meeting today. I want to understand what's most important to you in your time in the nursing home. So that might have been a good one for Polly. She's new to the nursing home. What is important to you in your time in the nursing home? Is there anything getting in the way of doing things you like to do or want to do? And then we can look at your medications in relationship to that. So again, these are just a list of questions which I think we should, even for young people, for myself, for others, I feel like these are questions we should be asking each other. The other thing that's helpful is to try to frame deprescribing as positive, right? No one wants negative. In doing that, again, lining them up with those questions. What matters to you? What you want to do while you're in the nursing home? So this is the example of Polly, which again was a real case that we changed a little bit. Polly, you told us that being able to stay independent and spend time with your family was important. In order to help you do this, we want to talk about discontinuing a couple of your medications that have a lot of bad side effects. The NyQuil and Ambien that you're taking for sleep may interfere with doing what matters most to you. This medication can cause dizziness, falling, and can worsen your memory. And then I'll sort of end with some things that we can do as family members and as residents is know your medications. Try to understand what your medications that you're putting into your mouth or what your loved one is taking, what they're for. And know that these medications, we should always be asking, not just get put on them and not ask again, but are they helping or hurting? Are they supporting your goals and your best health? Share your concerns with staff. So let your provider or any of the nursing home staff know if you have concerns regarding any of the medications that you are taking. And together, your team can determine if any of these should be changed or stopped, or maybe there's one that you aren't on and need to be on. Also, if you're experiencing any unwanted symptoms, tell the nursing home staff, the physician, or the nurse practitioner. There's something called a prescribing cascade, where people have symptoms and then we put them on a medication, and then that medication causes more symptoms, and then we put them on another medication. So most of the time when we have problems with medications, it's because we're using them to treat symptoms, and they're not really helping the underlying condition. So be careful with that one. And think about non-drug ways to deal with symptoms. This is sort of a process I want to tell you that the staff goes through, and this is called medication reconciliation. Reviewing for any of those high-risk medications every time you get together for a care plan meeting. These are a list of some of those high-risk medications, and again, they come from the Beers criteria. Secondly, thinking about doing regularly scheduled medication rounds with all the staff where they involve the resident asking some of these questions. Discussing any concerns the patient or family may have, and discussing deprescribing. And then lastly, I'd say that everyone has a role in deprescribing. Watching for medication responses and side effects. This says renew medication every 3 months. I said earlier every 1 month, so whatever your policy is in the facility. Watch for changes that can likely be from a medication, such as any change in functioning, sleepiness, falling, delirium, or any change in mental status. This, again, brings the 4 M's together. So here's Polly. Again, asking Polly what matters to her as you think about whether or not she can come off any of her 11 medications. Offering alternatives to Polly for pain and for sleep and for boredom. So thinking about, I'm not just going to take this medication away, I'm going to address your symptoms and how you're feeling. Encouraging physical mobility. Mobility, I'll say with a lot of confidence, helps almost everything, even pain, and there's strong evidence for that. And then connecting and socializing with others. Again, there are alternatives for sleep. This is a website that talks about, how important it is to use your bed only for sleeping, getting up in the morning, trying not to take long naps, avoiding caffeine, all these other things that can help us with sleep. Similarly, things that can help us with chronic pain that have fewer side effects. Massage, relaxation, physical therapy. Again, I'll end with usually less is usually more, less is more, and keeping Polly and all of our family members and our friends at the center of the conversation when we think about medications. And that's all for me. And if you have any questions, this is how you can reach me. Thank you for your time.